Okay, fine. So we'll begin with this case-based panel discussion. And so first of all, what's fertility preservation? The process of protecting or preserving sperms, eggs, or reproductive tissue so that a person can use them to have biological children in the future. So just to overview, surgery basically it can either render someone infertile by removing removal of reproductive organs. Similarly, chemotherapy effects on fertility by dose-dependent direct destruction of oocytes, follicular depletion, and cortical fibrosis. And there are a lot of notorious chemotherapeutic drugs, likely alkylatic agents, cyclophosphamide. They are very dangerous. Similarly, radiotherapy also impacts on the fertility. 14.3 gray of to an ovary in a woman over 30 years of age will usually render her irreversibly infertile and menopausal. So, just for a brief or glimpse, what are the fertility preserving options for female? So, ART techniques, embryo cryopreservation, oocyte cryopreservation, ovarian tissue cryopreservation, and medical and surgical techniques like ovarian transpositions. If we are going to give radiotherapy, then fertility sparing surgery and ovarian suppression. So, there is a big spectrum of ovarian cancers, from surface epithelial cells to germ cells to sex cord, stromal tumors, and metastatic. So we'll begin with the case number 1. So our 21-year-old unmarried engineering student presented with abdominal pain for a day and no family history of malignancy. On spot USG, she diagnosed a 10 into 8 centimeter septate, predominantly solid mass involving the right adnexa. Doctor shows prominent flow signal in the septa, no evidence of torsion. So Dr. Costa, I would like to proceed with this.
The ultrasound is suggestive of some neoplastic changes in the adnexal SOL. So I would like to get a better imaging for the mass. So definitely I would opt for a MR for this in this situation, and the CT chest and upper abdomen for the staging workup, not as a primary imaging modality.
Okay.
So MR pelvis for the characterizing the lesion, and CT for staging.
Anything else you would like to do?
I mean, from imaging or any other investigation, I would definitely go for a tumor marker. So, since she's a young girl, young and 21-year-old lady, so definitely I would include the germ cell panel for her. So, CA125, CEA, CA19, the epithelial markers, and the AFP, beta, ICG, and LDH as the germ cell markers.
Okay, fine. So basically, patient underwent CT, abdomen, and pelvis, and there was a multilobulated 10 into 8 centimeter solid mass with fibrovascular septa involving the right nexa. There was a post-contrast enhancement of the septa. Left adnexa was normal, minimal free fluid, no other positive findings, and definitely these are the tumor markers. So, what would be the possible diagnosis?
The possible diagnosis could be a germ cell tumor.
On the basis of markers, can you rule out something?
It could be a dysgerminoma or a immature teratoma.
Yeah, great. So basically, in dysgerminoma, there is the elevation of LDH and alkaline phosphatase, and definitely in this, there is the elevation of LDH and all other parameters are within the range. So there is the possibilities of having germ cell tumor. So likely it was a dysgerminoma stage 1A. So my next question to Dr. Divakar, I would like to proceed in this case. Will you advise fertility counseling? Will you refer this case to a reproductive physician, fertility expert, or would you recommend fertility preserving surgery in this case?
It is likely to be stage 1A dysgerminoma, and the left ovary seems to be normal. So this girl is a perfect candidate for a fertility preservation surgery. I'll offer her upfront surgery, and it will be right sampling oophorectomy. I'll preserve the left ovary, and I'll also do the sampling, nodal sampling as well, and then probably she might receive, depending on the type of the histology, she might receive chemotherapy or not. Depends on that. So I'll offer her a fertility preservation surgery.
Okay, and for this case, would you like to send the patient to fertility expert, or
yeah, of course.
Would like to explain by yourself?
Yeah, no, we have our team, so we usually send them to, we do send to a physician.
Okay. So basically, there are the factors that determine or helps in the choosing the patients, if we are opting for fertility sparing surgeries, if the patient is less than 40 years of age, desire to preserve fertility, tumor factors, favorable histopathology type, basically grade 1, 2 tumors, or there is no clear cell carcinoma, and on the basis of pre-surgery evaluation, willingness to follow up and appropriate follow-up protocols, patient can be taken off FSS. So, but in counseling, we need to take care of explaining that we might land up in the complete oophorectomy, and there might be chances of reduced fertility in future, even after having the FSS and future contralateral disease. So, Dr. Costa, what surgery would you like to offer? Lab cystectomy?
Like to take out the diseased ovary, so not a cystectomy, it should be always a right salping oophorectomy. And sampling of the lymph nodes, ipsilateral nodes, if you would be specific. And I would preserve the opposite ovary and the uterus.
Okay.
Excuse me, I have a question. With this background, why can't it be a dermoid?
Basically, in the mature teratoma and dermatitis, there is
All tumor markers are negative in any patient.
Yeah.
Another
So
differential diagnosis.
it can be a dermoid. It's a on frozen section diagnosis, so it can be a dermoid.
it's just there was the homogeneous solid tumor. There was nothing.
There are some sectors, uptake is there.
Yeah.
Yeah, we had the patient similar of the age group. We had a dermoid cyst, so we did a cystectomy and probably with the frozen section.
Yeah. So
We bang more on MRI in those cases,
Yeah.
so we see other features on MRI to
better delineate.
come to a conclusion.
Fine. So in these patients, we are planning for right salping oophorectomy. And so as we went inside the abdomen and intraoperatively, we find suspicious area in left ovary. So what do you think? What should we do? Should we go for biopsy or versus bilateral salping oophorectomy in this case? From it.
I would like to go for the frozen section biopsy first, rather than bilateral salping oophorectomy.
Okay, so one side will go for salping oophorectomy and another side will go for biopsy, and we'll see for the frozen report. So basically, if we are considering this case as a dysgerminoma, then DFS at 10 years is almost 90%, OS is 100% for all stages, and FS is recommended for all stages of dysgerminoma. And yes.
Sir, if it is going to be a normal, routinely you go for a frozen of the opposite ovary, or only if it is an abnormality?
If it's abnormality, otherwise we are not going anywhere, because that will hamper the fertility in future of that
So
ovary.
if it is going to be, in this case it is negative frozen.
Yeah, frozen was negative.
If it is going to be positive, sir?
Yeah, that I'm coming. Okay, so final HPR is left ovarian biopsy, no evidence of malignancy. Stage 1 immature ovarian teratoma, grade 3 involving right ovary. So how will you
Sir, in view of immature teratoma and grade 3, so I will give adjuvant chemotherapy post surgery, and that will be either 3-cycle BEP or 4-cycle EP.
So what are the cases where you would like to avoid chemotherapy, and particularly Johnson's tumor?
So in stage 1, grade 1, maybe in grade 2 immature ovarian teratoma, and stage 1 dysgerminoma.
Okay, so basically stage 1, grade 1 to 3
Yes.
where we can avoid chemotherapy, and and why not observation followed by chemo at relapse?
So because she is a young female, maybe she can tolerate the chemotherapy rather than putting her observation. If she relapse, then we treat. I don't.
Yes, germ cell tumors are basically quite sensitive to chemotherapy, and almost 80% of the patients attain fertility after having the chemotherapy. So that's why. And alkylating agent, 70% risk of amenorrhea, predominantly affecting primordial follicles, platinum 30 to 70, anthracycline antimetabolites less than 30%. So this is the chemo protocol. After 6 months of surgery and chemo, she get married and desiring pregnancy. And she has irregular menstruation and mentally depressed. Dr. Koso, how will you entertain that condition?
So I think she will need a psychological counseling first because she is depressed regarding what exactly she's regarding her fertility planning. And from the irregular menstrual, we should see the hormonal profile, how is the estrogen, FSH, LH level. And then I think since just 6 months from surgery and chemotherapy, I would not allow her to take pregnancy right now. At least we should give a year of interval from the chemotherapy and the surgery. At least a year.
So basically, if everything is in normal range and patient can be advised to go for pregnancy after 8 to 12 months post chemotherapy, and oocyte cryopreservation could be proposed to this patient. So basically, what's oocyte cryopreservation was experimented in 2012, and pregnancy rate lower than embryo cryopreservation. And oocyte, as we all know, it's the largest cell in the human body, abundant cytoplasm. Because of that, there are chances of making ice crystal while we are freezing. So a lot of chances of destroying this cell. So what are the good candidates? There are no partners are willing to use donor sperm post-menarche, can delay cancer treatment by 2 to 4 weeks. So these are the conditions where these candidates are good, and poor candidates who cannot delay the treatment and pre-pubertal. And this is about dysgerminoma, where we can go for in vitro salpingophorectomy and staging. And if there is bilateral dysgermination, then can go for oophorectomy and ovarian cystectomy on contralateral side. And fertility sparing surgery is giving good result in dysgerminoma. So coming to case 2, patient is a 33-year-old housewife, married for 8 years, L1, 18-month-old child with cerebral palsy. Had abdominal pain on and off for last 2 months, evaluated at primary health center, and USG showed right index of 15/15, unilocular, large chest with solid components, left index are normal, no ascites, CT suggestive of similar findings, and C125 normal, C19.9 normal, LDH normal. So, Dr. Divakar, what preoperative counseling you will advise, and what would be the surgical plan?
So she's 33. I think I'd like to add on to the germ cell markers as well. And then because it's a resectable disease, then probably surgery will be my first treatment modality. And as the first child is having issues with, he is a CP guy, so I definitely counsel her for fertility preservation, but only in case if it is germ cell tumor or it's a borderline ovarian tumor. I will not recommend a fertility preservation if it is a ovarian epithelial neoplasm.
Okay. So, patient's consent has been taken for BSO, and she insists that her husband will be informed of intraoperative finding before proceeding to BSO. So, in this particular case, would you recommend embryo cryopreservation?
Yes. Of course, yeah.
Okay. So, basically, embryo cryopreservation is right now this is the most established technique of having ART. The entire process is control ovarian hyperstimulation, site retrieval, fertilization, then cryopreservation. So pregnancy rate is almost 40% after a single embryo transfer. And married patients are a good candidate for embryo cryopreservation, but there are a lot of legalities with this as well, because there are a lot of divorce rate after developing cancer, particularly female patients. So there are the chances who will take care of that embryo. The partner is different. So a lot of problems. And so on exploration, mass involving the right head neck are right ovary not seen separately, and it was separable from ureter, no ascites, no mental deposit, but there was a 1 into 0.5 centimeter nodules or pouch of Douglas. What would you do, Dr. Amit?
Resect that way as well.
Okay. So in the head neck
frozen section.
in the next side.
The right head neck should be sent for frozen section.
Okay. So you will go for salpingophorectomy on right side.
Salpingophorectomy right side, and with the excision of the purity deposit, both should be sent for frozen section.
Okay. So on frozen, it's serous borderline tumor. And so anything else you would like to do at that time? in borderline tumor?
In borderline tumor, lumpectomy or lumpectomy are
So in most of the
there's no
time,
benefit of doing that.
histology, and only this one invasive implant in the pelvis. So probably you should do a complete staging, and the chances of recurrence is very high. So depending on the counseling, she can she can be offered a particular resolution, but again, it's the recurrence will be little higher compared to a mucinous staging.
It is a borderline tumor, so even if the lymph node is removed, and even if the lymph node is positive, it makes more difference in overall survival.
It's okay with Dr. what is saying, but the problem is the frozen section. You need a very experienced pathologist to report borderline serous tumor on a frozen section. So it's better to sample the nodes to be on the safe side, because if the final histopath comes as a serous epithelial cancer, so you are in a soup. So it's better to just sample, not do a systematic dissection.
yes. So
So, excuse me.
yeah.
So even for a borderline tumor, fertility spanning, we used to grade, we used to stage.
Right. That's what I'm saying. That's the basis.
So
For all borderline
even the
tumors, we need
fertility
to
spanning
stage-
is not there. We have to stage
Right.
this.
we need to stage the patient, but particularly in the reproductive organs, we can remove the salpingophractomy only. The rest we can do as per the staging protocol. So she undergoes fertility preserving staging laparotomy. Would you recommend fine? Although lymph node dissections do not make any much difference in the overall outcomes of the
It is serous histology, so not take a risk and ask for the lymph dissection rather than.
Agree. So final HPR is serous borderline ovarian tumor with micropapillary features, right ovary stage 2A, POD deposit shows tumor deposit. Would you recommend adjuvant chemotherapy? If so, how many cycles?
As it is a borderline tumor, but it has a POD deposit. So I have to check whether the POD deposit is a continuation of the same lesion or is a separate lesion. I have
It's
to
the
ask
same.
from.
It's the
It's
same.
If it's the same lesion, I don't need to give any adjuvant chemotherapy. If it's a separate lesion from the ovarian mass, then I think patient will need adjuvant chemotherapy.
Fine. So basically, use of adjuvant chemotherapy did impact the risk of recurrence and can recommend chemo if invasive implants are present. So there is a bit of controversy, but still in most of the literature, chemotherapy is not indicated in that particular scenario. So how do you follow up this patient? It's almost similar to ovarian cancer. And after 2 years, the same patient presented with a single 3 to 3 centimeter size pelvic deposit, CA125 is normal. And then what is the ideal management? Dr. Costa, surgical resection with complete DHBSO.
I hope the patient has
Still
not
patient didn't attain any pregnancy or something.
fertilized. So if not so, then I would again go for the same management, excision of the deposit and frozen section.
Okay, and fine. In that same frozen came invasive implant. So, and right now, would you like to give chemotherapy or something?
There is invasive component, the adjuvant chemotherapy is required.
So, okay. Or a patient didn't attain pregnancy in the duration. So, would you like to give the benefit of that thing to patient or not? Or the last patient to plan pregnancy, then if anything happens, then
Maybe prior preservation before starting chemotherapy.
Yes, that we can counsel for oocyte and or embryo preservation.
that is already done.
Okay, then we can put her on chemotherapy and then.
Okay. Fine. So coming to case number 3, 35-year-old lady, 35-year-old lady teacher married for 8 months, family history of ovarian cancer in mother and breast cancer in elder sister. Noticed abdominal distension for 1 month on examination, ECOG 1. Ascites present, 20 to 20 centimeter abdominal pelvic mass, PV examination fullness, and extraneous mass 5 centimeter from anal birth because it's free. C125 3200, no effusion chest, bilateral mammogram normal. CT showing loss of fat planes with rectum at places, moderate ascites, omental nodularities, left neck, nexa, and uterus normal. CT PCI is 5 by 39. What would you like to proceed further with? So,
Surgical staging.
fine. Surgical staging, you would like to go directly as there is a loss of fat plane with rectum or 5 by 35, it's okay.
Beforehand, image guided biopsy, because it's a metastatic disease.
Metastatic. Stage
So,
3.
Yeah, so it's pre-operative or pre-NSCT biopsy. Then plan accordingly, depending on the imaging. Whether it's
Okay,
detectable
so
or not.
in biopsy, it's serous adenocarcinoma, grade 3.
I think my preference will be to offer a neoadjuvant chemotherapy first, and then to later do a CRS, and also counsel for HIPEC later if she is in. It is just going to tell us. So for me, I'll do biopsy. I'll just take the cytology, cytic fluid cytology. If that comes out to be positive, we are ready to go for chemotherapy. There is no need of biopsy from the tumor.
Any further information we can gather? That's what I'm asking.
No, so to start chemotherapy, we need biopsy. Because of that, we are.
Sir, regarding the
Suppose this histology counts as a clear cell cancer ovary. So in that cases, I think neoadjuvant won't help. It is better to go for a primary CRS in those respects. So
That is the information you wanted.
yeah, I think
Morphology.
right, morphology.
So apart from if you are going for a neoadjuvant chemotherapy, I think we need a tissue diagnosis. I think so. Before with the cytology, no, we need tissue for, since she is 33-year-old, we need for molecular testing is coming, personalized treatment is there. I agree with. I think for this case, I think rectum should not be a problem. I think so. Primary cytoreduction will be sufficient. And you get the.
She's young. She'll be fit for. She's a fit candidate for CRS. She looks like a fit
I
candidate.
think we should go further. I think so.
Okay, so in DMG we have decided for
Tissue, yeah. She is
That's the
80.
important issue.
If we put this patient on a tumor board with everybody in there, 90 out of 100 times the decision would be neoadjuvant chemotherapy,
Yes, sir.
not primary cytoreductive surgery. And for that, I agree, we do not need a tissue, we need a germline BRCA because of our history, and we need a cytology to prove that this is malignant. And when they finally go for interval cytoreductive surgery, you can put the tissue for HRD mutation tests.
I agree. So in DMG, the case was discussed and planned for NSCT followed by dual cytoreduction plus minus HIPEC. But patient is worried and desirous of future pregnancy. So what would be the option for this patient, Dr. Divakar? These are the practical options.
So I will not offer her fertility solution at first place. But yes, of course, oocyte preservation can be done if the left ovary is normal.
Okay, but patient is married, why not embryo cryopreservation?
That is also an option that I can do.
Okay.
Sir, one question. I don't have much experience with this embryo and oocyte. I have tried patient sending, but the cost problem is that. And how long you wait for because you have to wait for 1 cycle, 2 cycle for retrieve the oocyte and embryo. So you wait for 2 months or 3 months for the treatment. You start treatment for neoadjuvant. That's a practical process.
So basically, what happened right now? This entire ART treatment is not dependent on the patient's cycle. So anytime we can start hormonal stimulations and we can harvest the oocytes. So it usually takes 10 to 14 days of time for harvesting the oocyte. And in a single cycle, if patient is early in the age, then she can give 3 to 4 or 5 oocytes in a single setting. So in that case, if she is willing for embryo cryopreservation, then that's the best option. We can have the embryos and can observe for 5 to 7 days. We can see the growth of the embryos up to the 4 cell stage or 8 cell stage. Up to the 4 it's okay, and then we can freeze those embryos. So usually that is done. If patient is not willing for embryo, then oocyte is the option. And there is not much literature for GnRH, particularly ovary, and genetic testing. I will come to this later. And
If the first stimulation is going to fail, you wait for the second stimulation.
no,
Because overall, if you see the fertility for this ART, it is only 40 to 50% the success rate generally.
no. For ART, it's if we are planting 3 embryos, it's around 70 to 80% in young patients.
So for the stimulation and to get the proper oocyte, you may not be successful in the first cycle itself for the stimulation.
Right now,
No,
yeah.
for practical reason, if the first cycle is going to fail, you're going to wait
So this is the patient choice, whether she want to go for second or
I think we should discuss directly with the patient.
Yeah,
Counseling is very
that's
important.
patient choice.
because I'm talking about the delay in treatment, because here it is a stage 3 disease.
No, sometimes patient is so much keen to have the kids, they can go for any extent.
But as sir rightly said, in stage 3 fertility with preservation,
Yeah, definitely we can.
There is some waiting at the risk of waiting.
no ma'am, if it is going to be stage 1 or stage 2, it's okay. This is stage 3 disease, I think oncology.
Agree.
I think we would.
Definitely. We can keep all the things on patient plate. What exactly she wants. She is the last person. Yes, of course.
I think
That's
for
why it is
serous
important.
epithelial tumor, we should still put our stand on this. I think we should not go for preservation.
Yeah,
It's a
I
metastatic
agree.
disease.
Yeah, stage 3 epithelial ovarian cancer, I think from oncology point of view, has to be neoadjuvant or straight surgery. You have, I think so. Fertility sparing, I think.
Still, particularly in our experience, in our experience,
This particular patient, I think the priority should be getting good cytoreductive surgery and getting the disease at hand.
Right.
Whatever it is, primary or fertility preservation is a secondary issue. The patient is desirous of pregnancy, I think we should counsel them, but that is not your first choice at this point.
Life is first choice.
so
Life is first
That
choice.
is priority.
And who will take care of the baby?
okay,
Yes,
fine.
later.
So patient is educated, she gets a genetic testing and she's found to be BRCA positive with pathological variant. What next?
So I think this is the same patient we are talking about.
Yeah.
So no role of oocyte preservation as everybody agreed, and then definitely neoadjuvant chemotherapy or primary CRS, and thereafter we can start on upfront PARP inhibitor therapy, which is being BRCA positive.
Okay, so in this particular patient, would you like to offer fertility sparing something? No?
No.
Fine. So post of HPR came as high grade serous carcinoma, right ovary, stage 3C. What adjuvant would you offer?
6 cycles of paclitaxel carboplatin followed by adjuvant PARP inhibitor.
Adjuvant PARP inhibitors. And how long?
For 1 year.
1 year path. Fine. So patient refuses for maintenance therapy and is on regular follow-up. She resumes menstrual cycle after 1 year. Actually, this patient underwent oocyte preservation. So can she plan for pregnancy right now?
She had undergo cytoreduction, no? So
Agree.
What about the uterus?
Let's just take it out there.
Agree. That's the
One question to everybody is, can we, if suppose uterus is not involved, can we preserve the uterus, taking on the ovaries? Yeah, for stage 3.
I don't think.
So basically, in some of the cases in literature where there was the no gross disease over the uterus, they had preserved the uterus, and under the lot of hormonal cover, they planned some pregnancies. But these are all experimental and not in the literatures.
Surrogate mother is the option. Surrogate.
Yes, that's the option, viable option.
Site is there.
So just 4-5 slides before closing this. What are the other options? Ovarian tissue cryopreservation. Basically, this is advised in the prepubertal female, and it's nothing to do with menstrual cycle. And this is a one-time procedure we can do at the time of surgery as well. Ovarian transposition that we usually do in the radiotherapy, CS cervix or endometrium, where we transposition ovary away from the radiation field. It should be at least 3 centimeters away from the field. These are the different locations where we plant, and these are the different scenarios where we can offer FSS and possibilities. And last, there are some literature, and in this they have told grade 3 or clear cell carcinomas was the only independent risk factor for survival of patient of reproductive age group. So in this particular set of patients, they weren't advised for FSS. Otherwise, there were in other patients there was almost 82.4% of successful pregnancy as full-term delivery. These are long-term results of fertility sparing treatment, and almost similar results. There are some data from the AIIMS New Delhi ART Center. It's last 5 year, 3 year because of COVID something. So in 30 patients, fertility preservation options were offered, and these are the different cases, and this for breast. So particularly there was a challenge, despite of doing fertility preservation, preserving embryo and oocyte, whether patients are coming for the pregnancy, still they have the interest to have the pregnancy and to attain all these embryos and oocyte. So still it's a question, and there are some guidelines. ASCA has given in 2018, first given in 2010, then updated in 2013, and then 18. So it should be discussed with each and every patient, and we should offer fertility preserving option at the earliest, and should refer the patient to the reproductive specialist, and should provide the full range of preservations. Embryo cryopreservation is the standard, oocyte is the second option, and oophoropexy can be done and where radiation is to be given. Conservative gynecological surgery should be offered in most of the cases. Ovarian separation, it has a role in the breast cancer, but still a lot of debate in ovarian cancer, and ovarian tissue cryopreservation, it's still experimental. Thank you so much.